thanks again to Manas and Manas for inviting me to participate in the Essence Shoulder course. And I'm really glad to present a talk about the role of posterior subluxation and possible treatment. If we talk about osteoarthritis of the shoulder, we can distinguish between primary osteoarthritis and secondary osteoarthritis. For secondary osteoarthritis, we know the exact cause that led to the degeneration of the shoulder joint. For primary osteoarthritis, it remains unclear what caused this degeneration. Usually it's age, but potentially there is also other factors involved. Recently, we performed a study analyzing different types of osteoarthritis, and what we found is that in cases with primary osteoarthritis and eccentric wear of the posterior glenoid rim, there is a significant association with male gender, higher body weight, and significant association with involvement in combat sports and weightlifting, as well as bench pressing. So it seems to be a fact that repetitive microtrauma can lead to posterior decentering of the humeral head and potentially to eccentric osteoarthritis of the shoulder joint. I show you another example of a patient. He was a young doctor who sustained a bicycle fall with a posterior shoulder subluxation. And you can see on the longitudinal MRI scans how the joint decenters posteriorly and how progressive degenerative change is taking place over the course of only 2 years. So there might be cases where patients have a quietly acquired static posterior shoulder instability that leads to early degenerative changes. We show this in a study where we proved that there is patients who progress from a first-time posterior shoulder dislocation or subluxation to a dynamic posterior instability and subsequently to a static posterior decentering of the humeral head. So it seems that a certain subgroup of primary shoulder osteoarthritis might indeed be secondary osteoarthritis caused by posterior shoulder instability. What is really interesting is patients who have a posterior decentered humeral head without any trauma that they sustained. These patients usually have initially no symptoms until there is degenerative changes who make them painful. The cause for this decentering of the humeral head remains unknown. You can see an example of a patient with bilateral posterior decentering of the humeral head, so static posterior shoulder instability or posterior shoulder instability type C according to the ABC classification. You can see that the humeral head has a posterior decentering on MRI and on CT scans. There's some dysplasia visible on the CT scans of the glenoid rim, and there's also a lack of cartilage or thinning of cartilage on the posterior glenoid rim, as well as a labral tear, at least on the right-hand side. What leads to this kind of static posterior shoulder instability is yet unknown, but there's different studies going on. And one of the studies we conducted showed that not only is the humeral head subluxed posteriorly, but actually the glenoid has increased anterior offset. As visible on the bottom right-hand side CT scan, you can see that the shape of the scapula can vary extensively, and if you have an increased anterior offset of the glenoid, this might lead to a relative posterior subluxation of the humeral head. We conducted further studies analyzing the scapulothoracic orientation as well as muscle volume in order to show whether there was associations of changes from the natural state that might facilitate posterior humeral head subluxation. And there's other study groups examining different topics as, for example, humeral retrotorsion and acromial tilt, but so far there is no clear answer as to the reason what causes this pathology. What can you do in terms of treatment? So if you have patients with static posterior shoulder instability and subluxation of the humeral head, and you have an excessive retroversion, it has been tried in the past to perform an open wedge osteotomy of the glenoid. This can work quite nicely, as seen on the postoperative X-ray on the bottom right-hand side. So you can build up the formerly excessive retroversion of the glenoid and improve the centering of the humeral head. Unfortunately, on the long run, the humeral head tends to stay posteriorly decentered, and this might cause even further problems when you perform these open wedge osteotomies. So these patients that we published in this small case series, they did better in terms of pain. Unfortunately, the head stayed decentered over time, which led to subsequent problems as shown on the X-ray follow-up. Another option is to perform the so-called post-articular coverage and shift procedure, which is an arthroscopic intervention where you can debride the posterior cartilage defect and then insert all suture anchors quite far into the joint at the border between the cartilage defect and the native cartilage. Then you can do microfracturing in order to improve the healing of the labral repair. And then with the help of suture lasso, you can pass the suture wires through the posterior capsular labral complex and reattach the capsular labral complex into the cartilage defect, while at the same time reforming the posterior bump, which improves the posterior stability of the humeral head. It is quite nice to know that in many of these cases the posterior labrum is hypertrophic, and this helps you to rebuild the bump and increase stability. We did a case series of about 14 patients, and what we saw is in the longitudinal follow-up over 2 years a significant improvement of clinical outcome scores. So we were quite happy with this short-term follow-up data for this minimally invasive procedure. If we saw recentering of the humeral head on the postoperative MRI, this does not mean that it stays this way. What we observed over time is a continuous decentering of the humeral head. So also with this procedure, we cannot recenter the head, and quite honestly, we did not expect this to happen. But nonetheless, it seems to be a viable alternative to the more invasive bony procedures that also are not able to recenter the head. Maybe we even need to think about other treatment options, as for example this patient with static posterior shoulder instability and early degenerative changes. You can see that it is not only a static decentering of the humeral head, it is also a dynamic posterior shoulder instability. I show you the same patient that repeats the same motion, but this time he has a shoulder pacemaker that activates the external rotators, which helps to balance the shoulder joint visibly compared to the pre-interventional state. So this might also be something that we need to consider in the future of adding surgical intervention and conservative treatment together in order to improve the outcome. So what can we do if the static posterior shoulder instability already progressed to a posterior eccentric osteoarthritis? There's the option of performing anatomical total shoulder arthroplasty. However, you have to be aware of the fact that the humeral head tends to stay in the posteriorly subluxed situation and also tends to stay posteriorly unstable, and this can lead to eccentric posterior wear of the glenoid component with early failure. Studies have shown that anatomical total shoulder arthroplasty unfortunately is subject to extensive failure rates, and the most popular reasons for complications and revisions are wear of the PE insert and generally instability issues of the arthroplasty, as the core is not very stable in this particular type of shoulder arthroplasty. A potential solution in patients with advanced osteoarthritis and advanced posterior subluxation of the humeral head, so the centering of the shoulder joint, might be reverse total shoulder arthroplasty that allows you to stabilize the center of rotation. However, this might not be the ideal solution, especially in younger patients. So in conclusion, static posterior shoulder instability type C, according to the ABC classification, can either be congenital or acquired. It is a chronic progressive pathology and a precursor of posterior eccentric OA, and currently it cannot be reversed, unfortunately. The arthroscopic post-articular coverage and shift surgery, which is a soft tissue intervention, can provide a symptomatic relief, as does glenoid bone augmentation in terms of posterior glenoid open wedge osteotomy or posterior glenoid rim augmentation surgery. However, also these bone interventions are not able to recenter the head. Anatomical total shoulder arthroplasty might be an option for the treatment of advanced posterior eccentric OA, but we have to be aware of posterior glenoid wear and posterior subluxation of the prosthetic humeral head. In cases with excessive decentering, and posterior instability of the joint, a reverse total shoulder arthroplasty might be the way to go. However, it should be avoided in young patients. Thank you very much, and thank you again for inviting me to participate in the Essence Shoulder course.